and good morning for those in Illinois joining us on the press conference today. We'll get started here in just a moment. For everybody on the phone lines, I'd like to remind you to please keep your phones on mute until called upon. That way it helps us to limit feedback on the phone. And without further ado, we'll get started. 9 members of the Polish military's medical corps will be in Chicago, or are in Chicago, to support the state's response to COVID-19. They're there from April 23rd until May 2nd. Polish doctors, nurses, and emergency medical technicians recently treated COVID-19 patients in Italy and in Poland, and they're visiting Illinois as part of the Illinois National Guard State Partnership Program with the Polish military. The medical corps officers will share lessons learned and best practices from their fight against COVID-19 in Europe, and will exchange information with medical professionals in Illinois. Joining us on the phone lines today are Vice Director of Strategy, Plans, and Policy and International Affairs, J5 at the National Guard Bureau, Brigadier General Thomas Hatley, the Adjutant General of the Illinois National Guard, Brigadier General Richard Neely, and from the Polish Military Medical Corps, we have Captain Dr. Jacek Siewiera. Gentlemen, without further ado, we'll go ahead and go for opening comments. And General Hatley, it's yours.
Outstanding. Happy to join you today, and many thanks to General Neely and Captain Dr. Siewiera for joining us today as well. I'll just give a brief overview of the SPP program. So created in 1993 after the fall of the Soviet Union, the State Partnership Program is a unique Department of Defense security cooperation program pairing the National Guard of a U.S. state or territory with a partner country's military, security forces, and/or government agencies responsible for emergency and disaster response. Originally focused on assisting former Soviet and Warsaw Pact countries in Eastern Europe as they sought to join Euro-Atlantic political security structures, the State Partnership Program today is a global, low-cost, and high-impact security cooperation tool that supports the national defense strategy by developing enduring relationships with partner countries built on mutual trust and shared values. The State Partnership Program helps to build partner capacity, improves interoperability, while increasing the readiness of U.S. and partner forces to meet emerging challenges. Currently, the State Partnership Program encompasses 82 partnerships involving 89 countries in all 6 geographic combatant command areas of responsibility. All 54 state National Guards have at least one partnership. The partnership between Poland and the Illinois National Guard was established in 1993, making it among the first ones since the program's inception. During Poland's transformation from a former Warsaw Pact member to an indispensable U.S. ally and NATO member, the Illinois National Guard has been engaged with their Polish counterparts in every step. Thank you. This concludes my opening remarks.
Okay, at this time, we'll go ahead and open up to, do we have, I'm sorry, General Neely, do you have opening comments?
Yes, I do, and I will be followed by Dr. Siewiera, who will also captain the head of the team, who will also have opening comments. So good morning from Chicago, and good afternoon to all those joining us from the East Coast. And thank you for joining us today to discuss the Polish medical team's visit to Chicago, Illinois. I'm Brigadier General Richard Neely, last name spelled Neely. Appreciate General Hatley's outline of the National Guard State Partnership Program and how the National Guard started with a partnership between 13 countries and how it's grown into 89 partnerships across 89 different countries. We not only in our communities, but we partner with first responders, and we partner with those in our communities in a lot of different ways. But the state partnership program is another great example of partnering across the National Guard. This makes a difference when we have to respond. And one of the strengths of the National Guard is that we build these enduring relationships, which we have done because we stay in our states usually for a number of years and have this. And as General Hatley outlined today with the state partnership program, I believe that Illinois has the best partnership going with the partnership that we have with the Polish military. It is the very best for a number of reasons, and this is why today we have this 9-person medical team from Poland joining us who have traveled to Illinois to respond to this COVID-19 fight. Our state partnership began in Poland in 1993 and was one of the first 13 partnerships with the newly emerged countries coming out of Eastern and Central Europe. Poland, this new country, which had just emerged behind the Iron Curtain in 1989, started a partnership with Illinois in 1993. Why Illinois, you might ask? Well, few probably realize that Chicago is the largest Polish city outside of Poland, with nearly 7% of the population tracing their descent from Poland. Over the last 26 years, nearly 27 in July, the Illinois National Guard has had over 400 training events with the Polish military to include exercises, leadership engagements, training events, and the integration of major weapon systems, such as the F-16 and the C-130 aircraft that we flew in the Illinois Air National Guard that is also flown by the Polish military. However, the best example of this relationship is the co-deployments that we've had since 2003, first starting in Iraq and then into Afghanistan. The Illinois National Guard has embedded personnel within the deploying Polish brigade for each of these rotations. These rotations are occurring every 6 months for the last 17 years, and it's still ongoing today. Today, our middle grade and senior officers who have moved through the ranks together with their Polish counterparts are still in the military. And and those within the Polish brigade as well. And so today what we have is some of the most senior Polish Army officers within the Polish military have served with guardsmen in this deployed brigade environment. We have fought side by side for many years, and now we fight this pandemic together. Today we are deeply moved by the incredible act of kindness and support from our friends from Poland who are joining us here in Chicago to share their experiences and expertise in fighting this disease and offering to lend a hand in some of the local hospitals. This team is made up of military and civilian doctors, nurses, and EMTs. Not only has this team been involved in COVID-19 fight in Poland, but is also deployed to Italy in response to the pandemic and have brought their lessons learned to share with us. This type of support is a testament to the 26-year relationship between the Illinois National Guard and the Polish military through the state partnership program. As the only state to have this type of cooperation during COVID-19, I'm very proud of the Illinois relationship with the country of Poland. Thank you for joining us today, and at this time I'll be followed by the medical team lead, Captain Dr. Siewiera. One second. Map change.
We are very pleased with the hospitality and the welcome which we experienced from the National Guard in the last few days of our mission. As General Neely said, our relations last 30 years, and in this period we fight against our enemies arm by arm, and we adjust to the type of the threat which we are fighting with. Today, the threat is the COVID-19. So the Polish Ministry of Defense and the Military Institute of Medicine with General Grzegorz Gielerok dedicates this mission consisting of medics, doctors, nurses, and EMT technicians to support National Guard in the effort of fighting with COVID-19. We are here from 23 of April, and since that time we have visited especially the Stroger Medical Center in Cook County, also with the Cook County Emergency Management and Communication of Chicago Center. We have made a great webinars during that visit with the ICU team, the head of the cardiology department, the head of the infectious disease department, and all these meetings were supported with the webinars for the personnel. It was very exciting to have the opportunity for sharing our lessons learned from Lombardy in the time of the biggest threat in that region of northern Italy. In the following days, we have been invited to share our knowledge via the webinars with medical personnel from Poland, and we have visited the Howard Heights testing center. Also, now we are visiting the DuPage County with two hospitals, St. Alex Hospital and Alexander Brother Hospitals, and the team is involved in consultations and experience exchange through all the issues regarding to COVID. So the organizational aspects of the medical approach, the organizational aspects of organization of hospitals, emergency departments, the triage sectors, and also the medical aspects of clinical procedures of diagnosing and treatment. In the plan, we have also visits in the Edwards Hospital and Glenbrook Hospital in DuPage County with a webinar prepared by Dr. Margaret Kierkegaard for their medical physicians and nurses, and also in the Hines VA Hospital on Friday, also supported with a webinar prepared for the Illinois physicians. Our team consists of 4 doctors. Within the group, there is a cardiologist, organization who have experience in intensive care and has been in Lombardy also. The Professor Churchwell, the intensive care, head of the intensive care department in Poland, and 2 anesthesiologists who were the chiefs of the group in Lombardy, which I had honored to command. But we got the paramedics and nurses with us. They are prepared for sharing their knowledge. This has happened in Stroger Hospital. So this experience is exchanging appears in every level of the professional services. And we are learning a lot from military personnel, from National Guard, and we are trying to provide the best practices which we had seen when the pandemic in Italy was increasing with nearly vertical curve. and slowing down to decreasing as well now. We have been the partners in the process, so we have some experience in how it was accomplished. Across Europe, we've got some important points, and we see some differences between U.S. approach and the European continental approach. So we have seen the collapse of medical health system in northern Italy, in Lombardy, when the crowds of the patients and their families were admitted to the hospital, and the selection of the patients were done when only one ICU bed was available among 15 patients with respiratory failure caused by the COVID-19. We have been there also when the decision-making process affected with shifts from the hospital services to ambulatory treatment process and the engagement of family physicians to the EMT services. The important fact was that the EMT services were prepared to admit physicians to the ambulance, and even some services were delivered in homes of the patients, and even preparing ambulances with the X-ray testing machine were considered on the crisis teams. We now know that the COVID-19 caused by the SARS-CoV-2 is the disease which has two phases. We see the differences in the mechanical ventilation of the phase 1 and phase 2. There are also sometimes opinions that these are different types of ARDS with a different compliance of the lungs. We know that these differences, we suspect that these differences are caused by the different time of admission of the patient, and they are not related to different types of the disease or manifestation or phenotypes, as we call this. We suspect that protocols for ARDS treatment should be adjusted to the ventilation of COVID patients, and we have some procedures for that prepared in Poland. We also use the scales for X-ray testing, which are substitute for the PCR test. When a lot of patients are admitted to the hospital with symptoms nearly to COVID-19, we are trying to make the X-ray with a scale from 0 to 18, like in the Lombardy, our partners, our doctors, done with six sectors in the lungs. And the number, the score of the scale depends on the status of the symptoms in the X-ray picture. That supports the decision to dismiss patient home or admit to the hospital above 10 to 12 points in the scale. We also have some insight and experiences which we exchanged with the personnel in the United States, in Illinois, about the personal testing and the transmission, horizontal transmission of the COVID-19 among the medical personnel. We have some insight in the regulations when the decontamination showers should be taken after the shift, as well as the isolation maybe in homes for the medical personnel, self-isolation if they want, if they can, if the possibility is. But we also have seen that one of the most important vectors of this disease might be the clothes which were taken from the hospital to their homes, to their families, and the procedures in that. We also have some insight in these. In the United States, this pandemic has totally different phase. Here, we don't have collapse of the administration of the medical services. We experience extending of the capacity of hospitals, and we are amazed how it was done by the National Guard in the McCormick, how it was done by the Cook County Emergency Medical Center, and we are amazed how data are supporting the decision-making process. It should look like this all the time. So at the end of my statement, I would like to thank for the National Guard, for General Neely, and for the team J5 with Major Adamczyk for how they received us and for their generosity here in Chicago. We will remember this as a sign of our ally for the rest of our lives. Thank you.
Thank you, sir. And with that, we will go to the phone lines. We'll take a few questions from the phone lines and come back here to the floor. First up, we have Tara Capt from McClatchy.
Hi. Thanks, everyone, for doing this. I was wondering if I could get one or two examples for what sort of advice Polish military leaders are taking on what permanent changes you think will happen in the Polish military due to coronavirus, and how you train, how you operate. Will everyone always have to wear a mask? Any sort of details. Thank you.
Okay, so the situation in Poland is quite different because decisions were made in a very early phase of this pandemic. We've got something like 300 new cases per day in all the country, and the country is something about 40 million of citizens and people. So the pandemic is now under control. But we are trying to get to the business as usual as much as this is possible. And we see some differences in the approach because in Poland we do not trying to, as in this moment, to provide screening tests for PCR method to all the communities. We are selecting tests and guarantee the testing, the free testing for the medical personnel. They can do it whenever they want. They can do it when they feel sick, when they have a contact with the COVID, even when they suspect that they have contact with the COVID. That is something what is a little bit different with the United States, where I see that there is an approach in which you are trying to provide this PCR test to as much citizens as you can. Time will show which approach will be more effective, but we see that it has to be adjusted to the situation in the appropriate country. So we know that we have to deal with this on the medical personnel level. And the second big difference which I see is the focus on resources in the ICU segment. In Poland, this is the weakest point of our medical health system. So there is possibility that if this pandemic will expand, there will be a lack of ICU beds. So Military Institute of Medicine has prepared a temporary architectures and projects for temporary modular ICU hospitals, which can be set it up in different places or in the country in different moments. This can be shifted to another locations where it can be needed. Here we see that the ICU beds are available, and you've got a capacity to take this and admit these patients for the treatment. And National Guard is focusing on providing a huge logistical challenge with containing patients with COVID-19 in facilities and isolatories. Medical isolatories like McCormick Place, which are impressive. this is the main differences which we see in approach.
Just a quick follow-up. Do you think that in Poland, military will go back completely back to normal, or will there be permanent changes?
Unfortunately, I'm skeptic about that. When I observe the progress in the vaccination and trials and the pharmacological trials, we also took this point in discussion with clinicians from the university hospitals here in Chicago, and we see that we didn't have any antiviral treatment until now, and there is a little chance that we will find golden growl for the treatment of the viral pneumonia in the nearest months. We will see how the vaccination can change the game, but I'm skeptic about that, and we have to be prepared for expanding this pandemic for months and even for years. Each time when the restriction in social distancing will be lowering down. So we are preparing for that to provide appropriate medical services to our citizens. I think it is very close to the approach which we see in General Neely perspective and National Guard perspective, also supported by the opinions of physicians around with the critical care insight.
Okay, next up, we've got Rose Thayer from Stars and Stripes.
Hey, thank you for putting this together. I was just wondering, I know you just provided some examples there, such as the ICU hospital beds, but have there been any instances maybe where things have gone the other way and you've been able to help out the folks in Chicago a bit with some lessons learned that have already been put into practice today?
1 second.
Okay, thank you for this question. Probably, yes, I believe so. There are big differences in our approach to diagnosing the COVID-19, and we began from the easiest points, like our advices for organization of emergency departments or the patient flow through the hospital tracts with the airlocks, with the decontamination locks, which were probably set it up, might be set it up in a more appropriate way when we see the ventilation, when we see the passage of the aerosol and the spray around the patients. We also have seen some points about the possibility of medical personnel infections, which we observed in Lombardy. They were using in the first phase of fighting the COVID pandemic. They were using the barracks, medical barracks from the field hospitals, and these barracks were quite low, with a 2.5 meters height, and with bad ventilation. So the ICU beds were too big to get inside to treat the patient properly with a good quality of services, and also the spray from the ventilator, from the bronchoscopy, from other procedures, so the bowel bronchoscopy examination. The spray of this procedure was in all around these barracks, within the barracks, and that was suspected as a cause of infections among the medical personnel. So now we see that the ventilation is one of the most important parts of organizing the COVID emergency department. We also talk about the approach to diagnostic and imaginary testing, because we know that we cannot provide tomography or more sublimate procedures, diagnostic procedures like PCR testing to all the community in one time. And if the situation appears that a lot of people, a lot of patients are admitted to the hospital with respiratory insufficiency, we are scanning them with the X-ray. It also relates to the condition of the patient, which can very rapidly deter without any signs of respiratory failure. It is quite broadly known right now. But we developed the scales for examining these patients and for cheap and fast scoring these patients. I spoke about it a few minutes ago. We are dividing these in 6 sectors, numbering from 0 to 3 each sector, and the total score is 18 points. That was something what was quite interesting for our partners within the physicians, within the Chicago Medical Service. We also have some insights about the usage of extracorporeal oxygenation, membrane oxygenation among the patients with the COVID, and the cost-benefit proportion in that procedure. We perform some of this procedure in Poland, and in Lombardy it was also provided to the patients, to the younger one, in the second phase. So these were also quite important insights, I believe, and our specialists in the ECMO treatment was inviting also the personnel from USA to cooperate in the scientific field with providing ECMO to COVID patients. So these were one of a lot of points which we were sharing with our partners.
Okay, thank you. We've got one more from the phone lines. Stacy St. Clair, Chicago Tribune.
Captain, what have medical personnel in the United States been asking you? Like, what are their questions and what do they want to know?
Okay. In first contact, we had more epidemiological issues about the phases of this pandemic, because in the big picture, most of the decision makers are focusing on the curves and flattening the curves and all these things which we do among the society to flatten the curve. But from the clinical point of view, we will also see the phases of the type of the patient related to demographic aspects. And we have seen in Lombardy that after 4 or 5 weeks of huge increase in admissions among the nursing homes, among the patients of the hospitals, elderly patients, after this time, something about 1 month, maybe a month and a half, the doctors were saying quite broadly that they are admitting much younger population, 50s, 40s, and the second phase of the pandemic was mostly involved with younger patients with better, with probably better outcome, but very badly reacting for the treatment. All the procedures which were implemented didn't shorten the time of treatment, so it was something like 4 or 5 weeks of treatment. treatment in intensive care units with drainage of right pulmonary field, the left pulmonary field, with tracheostomic ventilation, with procedures like ECMO, and the progress was quite poor. So these were the insights which we have seen in Lombardy, and we are exchanging this with our partners in here to avoid that situation.
Okay, we've got time for just a couple more before we head to closing comments. Next up, I've got Jennifer Griffin from Fox.
Thank you very much. I have a few questions and follow-ups. Are you seeing certain drug combinations that you were using in Lombardy or in Poland that are working in terms of treatment, and are you sharing those with your colleagues in Chicago? And you mentioned the clothes and protective gear, the clothes in particular of the medical workers being taken home as being a vector for the disease spread. If I understood you correctly, can you expand on that? And are you seeing that the disease is changing at all, or is this the same disease that you are describing in each of the phases, even though it's hitting different populations differently? Is it morphing?
Okay, thank you for the question. In the aspect of pharmacology, maybe at first. Unfortunately, we see that there is no optimal treatment yet for the COVID. There is no cause treatment, and there is no effective treatment in the viral phase. Because when we look at the progression of the COVID disease, we see that in each patient we observe two phases. The viral phase with replication of the RNA, virus RNA, and the second phase of the acute ARDS, which requires mechanical ventilation for the treatment and all the life-sustaining treatment procedures. In this second phase, there is a lack of viremia among the patients very often, and we are talking about the cytokine storm in that phase. So, in the first phase, viral phase, we don't have insights another than our partners from United States. The hydroxychloroquine is disappointing, remdesivir, maybe in some groups, maybe in some cases, could be providing some improvement, but it is not the drug which will totally extinguish the threat from viremia, and all these antibiotics which were suggested to use were also disappointing in that phase. We have spoken with our partners from hospitals about tocilizumab and its usage in the second phase with the ARDS phase. And this is the drug which provides some improvement in the laboratory test. So if we have the cytokine storm in the second phase of the COVID, we see that this drug provides lowering in interleukin levels with inflammatory response. But we are not convinced if this will be related to better outcome of the patient and less mortality. We are skeptic, unfortunately, about that as an anesthesiologist and intensivist. So my observation and my recommendation is that we have to be not good, not very good, but perfect in discipline of mechanical ventilation. We have to do best to do what we have done until now. We have to provide appropriate volumes, appropriate energy for the ventilations to avoid the lung injury, because these are the factors which are most important for sparing lungs. for better lung condition. If we get to the second question, so PPE, in Poland, we've got a broader possibility to use them. We use gowns, we use masks, FP3 masks, and we are using these as single-use tools. But we are excited about experimenting with recycling of these masks because this might be the good idea to provide the community access to high-level protection, respiratory system protection. These procedures can be done at home and are recommended by FDA right now. So this was one of the points which I was reporting to Poland. About this vectoring, virus particles are in the spray. We know that. And the spray, when the air is not moving, is falling down on the surfaces. On the surfaces, it can last for a long, long time. We count it in hours and days. So the spray, which is falling down on the medical clothes, on the scraps, or uniforms among the military personnel, medical personnel, these particles can be taken home. In some hospitals, especially infectious disease hospitals in Poland, there is a recommendation or obligation for the contaminating personnel with a shower with detergents after work and leaving their clothes, their scraps in the in washing rooms. I don't know how to say this, but hospital washing rooms with a detergent is mostly used with the patient's clothes. Not to take them home and to wash with a normal detergent as we use daily.
The laundering.
Yeah, laundering. Sorry for that.
No, good. Thank you.
Yeah. So it's a recommendation to use the laundering in a hospital for the professional detergent in a medical setting. And the third question was about. Could you repeat the third question?
Yes, it was about whether you are seeing the virus morph or change, or is this the same virus at the beginning?
Yes. All right, so we have seen and observed these disease for nearly 3 months right now in different regions. And we suspect that the manifestation and mortality of this disease is different among the locations mostly. We are not sure if this depends on this mortality depends on the mutation, or this mortality depends on the demographical factors. We know that in northern Italy, in Lombardy, the society is quite elderly. So the mortality in Lombardy was higher. We see that an example in Germany, in Poland, we observed less mortality, and there are some publications which state that these are factors connected also with the mutations, with the types A, B, C of the virus particle. But until now, we know that there are 40 mutations, 40 types of this virus already among these 3 months in Europe and in the United States. And I'm skeptic about finding differences in the types related to the particles. Mostly I see the differences in the period and the demographical aspect. The most important news about the symptoms are coming from the pediatric population, and these manifestations looks differently than in the adults. But it's too early to comment on that with high probability.
Okay, we've got time for one last one, and then we go to closing comments. Joe from NGB Magazine.
Hey, thanks for putting this together. This is a question for General Hatley. Does NGB or any of the states plan on bringing in other state partners for any other states in kind of a similar capacity as Illinois has done with Poland?
That's a great question. I would offer this, that up to this point, there's been a continuous dialogue between many of our partner countries in the states and territories that comprise the SPP program, many of which is just an exchange of lessons learned, best practices, challenges that they have encountered. I will say that this particular instance with Illinois and Poland reached out specifically to Illinois, which I would go back to kind of bridge upon my opening comments, just truly epitomizes the greatness that is the state partnership program, to have that freedom of maneuver, to have that comfort to where they can reach out to states and offer up assistance moving forward. That said, we are always open to our partner countries reaching out to us. There's nothing to preclude that, and there's are always great opportunities. I hope that answers your question.
Okay, that's all we've got time for today. At this time, I'd like to hand it over to General Neely for closing comments.
Well, thank you for that. That was a great answer from General Hatley. I echo those comments. It's the relationship that's built over so many years where that friendship is there, and a friend will reach out and ask questions about possibilities in that. And that's what we really have seen with this exchange here, the defense attaché reaching out to myself and based on conversations in Poland to see how we would do this, and we really had to look for ways to bring the team here and how the team would get transported and how we would work through customs and how we'd work through the policy of the presidential policy right now in place for no foreign flights and that. And so we had to work through a lot of those things, but fortunately, thanks to the help of the National Guard Bureau and a lot of different agencies, we were able to find our way. So again, I just want to say thank you for everybody for joining us today. It's a real honor to receive this team from Poland and to share their best practices with us here in Illinois. We're all learning how to respond during these challenging times. I believe sharing best practices, understanding how one country may approach it, or even the European approach compared to the U.S. I think we all have things to learn from this. And this 26-year, almost 27-year relationship will go on into the future based on historic visits like this reverse cooperation from the Republic of Poland, and we're deeply touched by their gratitude and for making this trip, for taking their time away, for being so disciplined in their processes to ensure that they're able to be here and to be healthy through the process as they travel internationally and as we visit a lot of different locations. These teams is very disciplined in how they hygiene and how do they decontaminate themselves during the day in each one of those to ensure that there is not a spread based on their contacts in different places. And I really appreciate all their dedication. So with that, again, thank you for joining us today, and thank you to the Pentagon press team for hosting this event. Thank you.
Thank you, sir. And on behalf of everyone involved, I'd like to thank the Illinois National Guard, Polish military, and the National Guard Bureau for being available to take questions today, and for the members of media who joined us today, both on the floor and on the phone lines. Thank you very much. Have a great day.